So I'm going to be talking about atrial fibrillation, which, as I'm sure you all know, is the commonest heart rhythm disturbance globally, and it's probably going to increase over the next 50 years with the rapidly aging population. One very important key message is that atrial fibrillation is not a benign condition, as I'm sure a lot of us were taught at medical school. This is data from the Framingham study, and in fact I took this slide off from the 2010 European Society of Cardiology guidelines. Let's just look at each one of these things. The mortality is doubled in patients with atrial fibrillation. Not something a lot of AF patients are probably aware of, not something we really like to tell them, but it's a fact. The risk of stroke is increased by more than 5-fold in patients with atrial fibrillation, and the most debilitating strokes are caused by atrial fibrillation. You get frequent hospitalizations in a lot of patients with atrial fibrillation. There is quite a significant morbidity, a big impact to the National Health Service. And in terms of quality of life and exercise capacity, well, symptoms are extremely variable. The majority of AF patients will be aware of palpitations, shortness of breath. Less commonly, you will see people complaining of dizziness, chest pain. Very rarely you'll see syncope, particularly if they've got other underlying conditions like hypertrophic cardiomyopathy or severe left ventricular dysfunction. But palpitations and breathlessness are the commonest things, and this really does have a significant impact on a lot of people's quality of life. More specifically, it has a variable impact on left ventricular function. The left ventricle can be completely normal, or if you've got pre-existing structural heart disease, left ventricular function can actually be destabilized by going into atrial fibrillation. And conversely, if you start off with a structurally normal heart, then in a minority of patients at least, the atrial fibrillation itself can result in a cardiomyopathic process, the so-called tachycardiomyopathy. And restoring these people to a normal rhythm causes complete recovery of left ventricular function. So it's not a benign condition. It has a significant impact on a substantial proportion of the population, and it needs to be managed aggressively. So what should the management strategy be? I'm sure you're all familiar with this flow diagram, but I'll just go through it to highlight some of the key sort of cornerstones of atrial fibrillation management. Let's just start off with a patient who you see in your surgery. For the first time, you've diagnosed atrial fibrillation. Of course, the best way to diagnose it is to do an ECG. Or, if the symptoms are less frequent, as Mark pointed out, you may choose to do some form of more prolonged ECG monitoring. But an ECG is the gold standard diagnosis. An irregular pulse that you just check could also be due to multiple ectopic beats, and it can be quite misleading. If the atrial fibrillation you can accurately say has been present for less than 48 hours, which I personally find quite difficult to do, but let's just supposing you could, there is an option to actually cardiovert these patients, either medically or electrically, for which of course they'd have to come to A&E, and you can restore sinus rhythm that way. And then depending upon what their risk factors for stroke are, they may or may not need anticoagulation afterwards. In practice, it's either very difficult to tell whether when they went into atrial fibrillation, or they're not particularly symptomatic with it, in which case the correct thing to do in the first instance is to instigate proper rate-controlled treatment, particularly if they are very tachycardic. And following that, they should then be referred to a cardiologist so that they can be considered for some form of rhythm control. My own starting point whenever I see patients with atrial fibrillation is that everybody is for rhythm control, because I think the outcomes from rhythm control are far better than just rate control on their own. Okay? So everybody is for rhythm control, the natural endpoint for which in the current era is an AF ablation. Antiarrhythmic drugs are good in the short to medium term, but the majority of people after about 12 to 18 months will start to have a recurrence of their symptoms despite ongoing antiarrhythmic drug therapy, and therefore an AF ablation is usually indicated. So if I ever see a patient for the first time with atrial fibrillation, I immediately think, am I ever going to be performing an AF ablation on them? And if the answer to that is categorically no, because they're too frail, too unwell, then I would go down the rate control algorithm at that point. Otherwise, I would still consider rhythm control. And that is regardless of their underlying structural heart disease, whether they've got mild or severe left ventricular dysfunction. In fact, I would say to you that the worse your left ventricular function is, the more you stand to gain from being in sinus rhythm. And so we should be considering people with even severe left ventricular function for rhythm control if it is safe to do so. And you'd be surprised how many people's left ventricular function will actually improve. Maybe not normalize, but you may get a significant improvement in their left ventricular function just by restoring sinus rhythm. So I never write anybody off for rhythm control. One of the cornerstones, as I'm sure you all know, of AF management is to prevent stroke. For me, that is the first thing you do. Everything else comes secondary to it. So obviously you would assess their risk for stroke using the CHADS-VASc scoring system. If their CHADS-VASc score is greater than 1, if they're male, or more than 2 if they're female, anticoagulation is indicated, probably indefinitely. Up until relatively recently, the one drug that we had available was warfarin. Warfarin's been around for almost 100 years, and it's been used for stroke prevention for almost 50 years. So there's a lot of data on warfarin. It's got a pretty good track record, but as you'll see later on in the talk, it's also got lots of problems. More recently, of course, we have the novel oral anticoagulant drugs. You'll be familiar with dabigatran, rivaroxaban, apixaban, and more recently, edoxaban. If patients are deemed to be unsuitable for any form of anticoagulation because they've got some underlying hematological condition, or more commonly, they've actually had previous significant bleeding complications, then of course, again in the current era, these patients should all be considered for a left atrial appendage occlusion procedure. And the way we actually deal with these patients, certainly at the Barts Heart Centre, is that we have a regular multidisciplinary team meeting where we have a group of electrophysiologists, hematologists and neurologists, and these patients are all discussed, and then and only then will we determine whether they are suitable for a left atrial appendage occlusion, or indeed if they've previously been on warfarin and had a bleeding complication, would a NOAC be a suitable alternative? Okay. Let's talk a little bit about rate control and the sort of algorithm that one should employ. For all patients who've got atrial fibrillation, everybody must have an echocardiogram to assess their left ventricular function and their valves. And the one important blood test that most electrophysiologists will check in just about anybody with an arrhythmia is their thyroid function. Okay, if they're thyrotoxic, the treatment actually is to treat the thyroid and treat the atrial fibrillation as a secondary thing. If the left ventricular function is good, then you have a choice of drugs that you can use for rate control. You'll probably need a combination of drugs, so typically beta blocker, plus or minus digoxin, or a calcium channel blocker such as verapamil or diltiazem, again with or without digoxin. It is most rare to actually have patients on all three agents. And if that is going to be required, then they have to be monitored very, very closely, because they can get profound problems with bradycardia when you combine all three. Particularly in the elderly population, as Mark alluded to earlier, you will see patients who have problems with tachycardias, where their heart rates are greater than 140 or 150 beats per minute, and at other times they become very bradycardic, where their heart rates are between 20 to 40 beats per minute. This is atrial fibrillation with tachycardia and bradycardia, and in these individuals, one should implant a single chamber pacemaker which takes care of the bradycardias, allowing you to then play around with the other drugs to see if you can slow their heart rate down appropriately. The ideal range for rate control should give you a mean heart rate in the range of about 80 to 90 beats per minute. If you saw that on a 24-hour monitor, I would say that that would be good rate control in somebody with atrial fibrillation. If despite implanting a pacemaker, and you see this in a minority of patients, they are still getting real problems with tachycardia, then we would go on and perform an AV nodal ablation procedure on them, following which drugs like digoxin can probably be stopped, and an AV nodal rates and atrial fibrillation. If you do an echocardiogram and the patients have actually got impaired left ventricular function, the most important thing to do is to refer them to a heart failure clinic and a heart failure specialist nurse to ensure that they are started off on all the appropriate prognostic heart failure medications, one of which will of course be a beta blocker. And if that doesn't give adequate rate control of their atrial fibrillation, then again, digoxin may be required. The same thing applies for people who've got tachycardia and bradycardia. They will require a pacemaker, but it's usually a biventricular pacemaker with a left ventricular lead because they've got impaired left ventricular function. And again, if there are problems with rate control despite that, an AV nodal ablation is very, very good treatment for these patients. If the left ventricular function is 35% or less, then of course they may also require an ICD. How about rhythm control? Well, again, you're going to do an echocardiogram, and if they've got impaired left ventricular function with or without coronary disease, again, aggressive treatment with heart failure drugs. And then you have a choice of the sorts of antiarrhythmic drugs that you could use to keep them in sinus rhythm. And I find this group of patients quite difficult because in order to use drugs like sotalol, you would actually have to stop a prognostic beta blocker like bisoprolol. And this is something I used to do quite routinely many years ago, and I've stopped. I've had a number of patients who the minute you start sotalol rather than bisoprolol, their heart failure actually destabilizes even though they're still in sinus rhythm. And so I try and avoid using drugs like sotalol or dronedarone. I would give them amiodarone for a period of no more than 6 months. And I usually use the amiodarone to facilitate a DC cardioversion procedure. And once sinus rhythm has been successfully restored, I tend to stop the amiodarone after about 3 months. 3 months is adequate time for you to actually get a handle on whether their symptoms improve in sinus rhythm and indeed whether their left ventricular function improves. But after that, in people with impaired left ventricular function, one would just treat them aggressively with heart failure drugs, and if they then get a recurrence of symptomatic atrial fibrillation, they should all undergo an AF ablation procedure. And these patients actually do very well if they're selected appropriately. On the other hand, if you start off with good left ventricular function, well, once sinus rhythm has been restored with a cardioversion, you've got a nice selection of drugs that you could potentially use. Flecainide is the one that one tends to use very commonly, but there's also diazepyramide, propafenone, sotalol, perhaps dronedarone, to maintain sinus rhythm. But as I said earlier, these drugs are good in the short to medium term. But the majority of patients, after about 12 to 18 months, will start to have a recurrence of their atrial fibrillation despite ongoing antiarrhythmic drug therapy. And if that is causing significant symptoms, these patients also all do very well with an AF ablation procedure. If it's paroxysmal atrial fibrillation, the success rate of an atrial fibrillation ablation procedure is of the order of 90% now. It can be done with a cryotherapy with a balloon, potentially even as a day case in some patients, and operating time is about 60 to 90 minutes sometimes. It's really revolutionized the treatment. Of course, if you've got persistent atrial fibrillation, more extensive ablation is required, though with recent data, perhaps the way we're going to go is to just do very limited ablation like we do for paroxysmal atrial fibrillation, even in the persistent population. I talked about stroke prevention being a cornerstone of atrial fibrillation management. I think this is another very important cornerstone of AF management. It's no good us cardioverting patients, treating with antiarrhythmic drugs or even an AF ablation procedure if we're not actually going to treat the underlying cause of the atrial fibrillation. And here I've listed some of the key things that you'll find in the majority of patients with atrial fibrillation. It is very, very important from the moment that they are diagnosed, even before they come to see the electrophysiologist, that they have aggressive treatment for each one of these sorts of underlying causes. Okay? And there's very good evidence for this. This is a study that was published from Australia a couple of years ago. And what they did was they took a cohort of patients with atrial fibrillation and they did ablations on all of them. They then randomized them to two groups. One group had the traditional routine clinic follow-up with the usual drugs, whereas the other group were given aggressive risk factor modification in a specialist clinic. And if you look, I'm afraid you can't read it very clearly, but across just about every sort of symptom score, quality of life score, the red line represents the people who have actually had aggressive risk factor modification. They're actually doing much, much better. In terms of the global well-being score, which is this score here, the people who've had risk factor modification also do better. It's pretty common sense, but no one's actually demonstrated it before until this particular study was done. And if you look to the right-hand panel, they're actually looking at prognostic data. And again, the people that have had risk factor modification over almost a 2-year period seem to have far better outcomes after their AF ablation procedures. This is after one ablation. This is after multiple ablations. On average, it will be about 2 to 2.5 ablations per patient. They still do a lot better. So an AF ablation is not a panacea. It's got to be working together with medical therapy and aggressive risk factor modification, and only then do you see the full benefit of ablative therapies in atrial fibrillation. This is some of our own data from St Bartholomew's, and as you can see, over a 7-year period, we followed up a number of patients, and again you can see that of the patients that are free from atrial fibrillation, their stroke-free survival is much, much higher than those that have actually had a recurrence. If you actually look at certain other outcomes, the risk of stroke, the risk of dying, the risk of stroke or dying, these are AF patients who've had just drug therapy alone, rhythm control or rate control. These are people that have actually had the ablation, and the white boxes here represent the general population. You can see that actually having an AF ablation does seem to confer some sort of prognostic benefit. Okay. Dronedarone is the only drug that has actually been shown to have some prognostic benefit. The other antiarrhythmic drugs don't. Okay. The thing about data like this is that it's very registry-based data, and there are no real randomized controlled trials that have mimicked this. However, there was a study published from the United States a couple of years ago which did actually show that if you have a successful AF ablation, the risk of stroke and the risk of dying does seem to come back down again. There's a lot of talk about the novel anticoagulant drugs, and I just want to take a few minutes to go through some of their properties and what the implications are. These are the key anticoagulant drugs that we have available to us today. Obviously, warfarin, dabigatran, rivaroxaban, apixaban, and most recently, edoxaban. You'll all be aware of their mechanisms of action. These are, as you can see, the novel oral anticoagulants, much, much more precise as to where they target the clotting cascade. Warfarin, by comparison, has a far, far more extensive effect. The other thing to highlight here really is the onset effect with warfarin can take 72 to 96 hours. There's a few unfortunate patients who still don't have therapeutic INRs even after a couple of weeks. By contrast, the novel oral anticoagulants are effective within a few hours. Okay? And of course, no monitoring is required for these, making them ideal drugs for patients to take. This slide actually highlights one of the key problems with warfarin. The blue bars actually show you INR control in people who are actually in a clinical trial. So they're intensively monitored, probably far, far better monitored and closely than people in the real world, which is the white bars. But even then, only 66% of patients are actually maintaining a therapeutic range of 2 to 3. And that's in a clinical trial. It's a lot worse in the real world. So there is a huge cohort of patients who are either going to have strokes or they're going to bleed simply because their INR control is not optimal. And usually these are patients who are quite sensible. They take their drugs religiously. They avoid the variety of foods. They watch how much they drink. And for no reason at all sometimes, the INR still fluctuates. It is a real problem with warfarin. There was a very good meta-analysis done of all of the different novel oral anticoagulant trials very recently. And I've taken some of the key take-home messages out of it, which I think are actually very, very important. And I'm just going to take a few minutes to go through these. First of all major bleeds were found to be lower with apixaban, the 110 milligram dose of dabigatran, and edoxaban compared to warfarin, whereas dabigatran 150 milligrams and rivaroxaban had the same risk of major bleeding as warfarin. Secondly, all NOACs have a lower risk of intracranial bleeding compared to warfarin. Thirdly, it was only edoxaban 30 milligrams that reduced the risk of gastrointestinal bleeding significantly. Both dabigatran 150 and apixaban were better than warfarin at reducing all strokes and systemic emboli. But only dabigatran 150 was better than warfarin at reducing ischemic strokes. Edoxaban has got the lowest risk for major and gastrointestinal bleeds, followed by apixaban, but rivaroxaban, interestingly enough, was the worst. The 110 milligram dose of dabigatran and edoxaban had the lowest risk for intracranial bleeding, followed by the other ones, and not surprisingly, warfarin was the worst. Rivaroxaban had the lowest risk for myocardial infarction, followed by apixaban. And dabigatran 150 has got the best outcome when you look at a combined endpoint of stroke, systemic embolism, all strokes and ischemic stroke, followed by apixaban. And in fact, the European Society of Guidelines actually recommend using dabigatran 150 milligrams in patients suffering an ischemic stroke whilst they were on rivaroxaban or apixaban. Warfarin has got the worst safety and efficacy profile of all of the anticoagulant drugs. And the latest iteration of the European Society of Cardiology guidelines would consider a NOAC as your first-line option in non-valvular atrial fibrillation. If you've got valvular heart disease and atrial fibrillation secondary to that, warfarin is still the correct treatment. Okay? So how about some practical issues that perhaps you may have come across with NOACs and warfarin? What would you do if you wanted to switch a patient from a NOAC to warfarin, let's just say? Well, you can actually start warfarin with the novel oral anticoagulant. You don't give them a loading dose, but you can actually start the two drugs concomitantly. You've got to check the INR regularly just before the next NOAC dose is due, because sometimes the NOACs can affect the INR reading. And once the INR is between 2 and 2.5, you discontinue the NOAC and just continue them with the warfarin. The INR has to be checked 24 hours after the last NOAC dose, and for the first month after they come off the NOAC, the INRs can fluctuate, and therefore you need to keep them under very close observation. This admittedly is quite rare. I don't often have to change people from a novel oral anticoagulant to warfarin, but if you had to, that's the way you would do it. How about the other way around? This is perhaps a bit more frequent. Well, if the INR is less than 2, you can stop the warfarin and give them the NOAC straight away. There are no concerns. If the INR is 2 to 2.5, you can stop the warfarin and start them off on their NOAC the following morning. It's quite safe to do that. But if the INR is 2.5 or greater, well, then you would stop the warfarin, and then you would have to recheck the INR at such a time when you think it's going to be between 2 and 2.5. And that will, of course, vary depending upon the initial INR. And then you'd start the NOAC. So that's a bit more fiddly, and you may need to refer them to an anticoagulation clinic or some such system that you may have whereby you can monitor the INRs closely. If you start the NOAC with the INR at 2.5 or greater, you do increase the risk of bleeding quite significantly. How about if you've got patients on a NOAC who are going to go for some surgery or other procedure where they need to discontinue the anticoagulation? Well, you would want to switch them to a low molecular weight heparin, in which case you can stop the NOAC and start the low molecular weight heparin when the next NOAC dose would have been due, because it has a very short half-life and it's very, very predictable. You will also have patients who've had percutaneous coronary intervention, got drug-eluting stents, and they may be taking aspirin and or clopidogrel. What if they then go into atrial fibrillation? What do you do? Well, in the current sort of era, most people with drug-eluting stents will probably need to be on aspirin and clopidogrel for at least 12 months. But in practice, if you talk to most interventional cardiologists, they would probably be happy for one of the antiplatelet drugs to be discontinued after 3 to 6 months and for them to be anticoagulated at that point. If you combine a NOAC with aspirin and clopidogrel, the bleeding risk does go up significantly. So after 3 months, you would stop, I would say, aspirin, and you would run them with NOAC and clopidogrel indefinitely. The bleeding risk is still a bit higher, but it's still safe to do from the standpoint of their stent. The final thing, and Mark's already mentioned the Reveal Link loop recorder monitors. These are so easy to put in, as Mark has demonstrated. Increasingly, I think they're going to be used in patients with cryptogenic stroke and asymptomatic atrial fibrillation. And I get a lot of inquiries from stroke physicians wanting to know if we can implant loop recorders in these patients. And there's very good evidence that actually if you implant loop recorders in a lot of these patients, you will find atrial fibrillation as the underlying cause of their stroke. Thank you.